All right, excited to continue our discussion of hair loss with you again today. We're going to be talking about the different interventions. So we talked about all the ways you can lose your hair. Now we're going to talk about all the ways you can save your hair. So I think a really good place to start off would be like, what are the most effective treatments? And this isn't perfect methodology because you're looking at the number of new hairs per centimeter squared, which is going to greatly depend on how many hairs per square centimeter your baseline population has. If somebody is barely thinning, they're going to have a lot stronger of a response, a greater number of hairs. But that relative improvement, like if someone has, let's say, 200 hairs per square centimeter and they have a 10% improvement, well, that's 20 more hairs per square centimeter. Not really going to be perceptible in that person. But if someone has lost half of their hairs, they have 100 per square centimeter, and they have, 20% improvement is going to be 10 hairs, but 10 hairs for that person is not going to be significant of an improvement. So just something to bear in mind when we're looking at the data here and ordering these from most effective to least effective. I don't think there's any surprises here. Were you surprised by any of these results in terms of what was found to be, most effective, least effective?
I was not surprised by any of the results. I was surprised by some of the discussion that we can get into later. Also, nice shirt without any planning. Regarding the efficacy of treatments, that brings up a good point regarding selection bias and even the subjectivity of something like a Norwood scale. So I believe we will try to rank most of these interventions on the Norwood scale, Norwood 0 being wonderful, a Norwood 4 being not so much, and Norwood, 6 or 7. Hopefully, none of these treatments will rate that, but you never know. So it just goes to show that in one study to study, you can have two different clinicians rank someone differently on a Norwood scale. It's the same in a lot of things in aesthetics. I believe Alec and I talked about this. So, the efficacy of a neuromodulator could be rated differently. Like one clinician could say it wore off then, one clinician could say it wore off then. So that's something to keep in mind also when looking at systematic reviews and meta-analyses for these products. So with all that being said, shall we dive into the first one?
Let's do it. So this was a paper, and this actually came out 2022, so this is fairly recent. And they looked at basically your very common treatments. So Dutasteride, Finasteride, Minoxidil, and what works and what doesn't. And the most effective treatment was Dutasteride, 0.5 milligrams per day. Next up on the list was 5 milligrams per day of Finasteride. Next up was 5 milligrams per day of oral minoxidil. So you kind of have your, top three there, which really it's like, you pick two of them and hopefully it's not Dutasteride and Finasteride.
Yeah.
Although there was a case report that did publish that we came across. So that was interesting. But in any case, if you're looking at like the most aggressive hair loss regimen you can do with just these oral medications, very minimal time commitment, but also it's going to be, higher risk. You're going to end up with daily Dutasteride, 0.5 milligram, daily Minoxidil at 5 milligrams. And hopefully you're not going straight to 5 milligrams. I think responsible clinicians are tapering people up so that they don't stand up and fall over or go to the gym and lift a weight and fall over or get 5 pounds of fluid around their ankles and say, what's going on here? Am I having heart failure? All these sorts of things. So I wasn't surprised to see that as the big three. Below 5 milligrams of minoxidil, you have 1 milligram of finasteride, then the 5% topical minoxidil, which for some time now we've had some data showing that oral minoxidil seems to be superior. Even in, I think, perfect compliance, I think that the oral is just going to be stronger. And you're just going to get that more consistent spike in the minoxidil sulfate, the active molecule. And then we have 2% minoxidil, which I believe it was 2 or 3%. That was approved by the FDA back in the 1980s. So it's been around for a long time. And now you see people using even like 15% minoxidil. But we don't have data from meta-analyses to pull for that yet. So hopefully those will be done in the future. I do encourage people to look at that. And then the very last thing we have is 0.25 milligrams of minoxidil orally per day. And that was found to be the least effective out of this particular lineup. So like I said, no surprises here, and that's kind of the top to bottom analysis.
This would also be an efficacy tier list. So maybe YouTube videos do well if you have a tier list, right? So the top tier would be for efficacy, but not necessarily for the best choice for every patient. For that, you'd have to weigh the risks and the benefits.
Yeah, we could probably make a meme out of it too.
Yeah.
All right. Then in treatments that are not necessarily mainstream or largely spoken about, there is neuromodulator, which I know you discussed with our friend Alec McCarthy, who has been heavily involved in the research and talking to leading clinicians in this space. And this is the template here. So basically you see exactly where you're putting these. In this case, it was 5 units of botulinum toxin. The brand they used was Botox, but you can certainly use your neuromodulator of choice because the effect is going to be the same. And we hinted at the theory of this, right? So it's the scalp tension that's higher in androgenic alopecia, and that's going to deprive the hair follicles of blood flow, oxygen, nutrients, and increase that reactive oxygen species, inflammation, which we'll talk about as well.
Fortunately, you don't have to massage your scalp for 6 hours a day for this to work.
Yeah, or apply some sort of gimmicky device that probably doesn't work.
We also alluded to this in a previous podcast, but particle size of your neuromodulator does matter if you're going to microneedle it, but not if you were going to inject it like this.
Yeah, if people are particularly interested in that, they could check out the Alec McCarthy episode, which I found to be really interesting. So going down to see how well this works, there are progress photos. Here we can see what was labeled a excellent response. So, I mean, this is really significant hair growth. This was a single treatment, and they go back 6 months later, and that's when they're doing these follow-up photos. So, I mean, this would rival what someone who is a really good responder to Finasteride or Minoxidil might experience. And the time commitment is however long it takes to schedule the appointment, get these injections, very minimal effort and non-hormonal, which is something that a lot of people are very interested in because they don't want to manipulate DHT and sort of open that can of worms. Some people feel very strongly about their DHT, and there are non-hormonal options. I think that's good for people now. Unfortunately, doesn't always work. So we have the photo right below that where this person did not respond. But this was, I think, 5 out of 6 or 6 out of 7 did respond in this study. So basically, if someone has a higher scalp tension at baseline, I think they're much more likely to respond because then you're treating the underlying cause or at least a contributor.
Yeah, this is another good example of publishing all your data. It's good that, obviously they hypothesized here that it would work with many people, but it does not always work. Of course, the discussion regarding this is if you have less tense scalp muscles or less thick, less tight scalp muscles, less hypoxic tissue damage, less death of the follicle. On another note, I love how you said some people feel very strongly about their DHT. Their androgen receptor may feel more strongly or more weakly about it as well.
Yeah, I think it's an interesting conversation, and people have a lot of great questions about this area. And there's also the subjective component to it, just like there's a subjective component to, medicine, and particularly in aesthetics. You have clinical expertise, and then there's, objective and subjective that kind of are married there to create a truly individualized medicine plan. So everybody's a little bit different. And then one of the things that we hear people talk about is like, okay, how long is this going to last? Botox, probably people doing that every 4 months is probably as often as you would need to do that. And I know you and Dr. McCarthy, PhD, discussed ways to extend the duration of the toxin so people can get a little bit more bang for their buck. So again, check out that podcast. But we have some long-term follow-up studies now. So this is one with Minoxidil. And this was actually just the 2 to 3%, which I thought was particularly impressive because everybody's using 5% now. Even, women are using 5%. Dermatologists will tell them, don't waste your time with the 2%, 3%. It does work, but people want results faster and they want more potent results. And 5% is the way to get there. You can have more side effects like body hair growth and, some fluid retention, even with a topical solution. I think that's important for people to remember.
Yep. Is there an equitable dose for topical minoxidil and oral minoxidil from a standpoint of like serum minoxidil levels or even serum prolactin levels?
That's hard to say. I mean, if you use 1 milliliter of 5% minoxidil, you're putting 50 milligrams of minoxidil on your head. So some of that does go systemic. I don't know what the blood levels exactly are. I'm sure that there's some data out there, but I suspect that it's still, even if you're putting on a couple of milliliters of 15%, you're not going to get the same active levels or the same levels of the active metabolite, the minoxidil sulfate.
Correct.
Which is actually also the blood pressure lowering component of that medication. So I think that you're taking 5 milligrams once a day, you're going to get a big spike. And I think that spike alone is enough to signal the hair follicles to shift into that anagen phase. I guess we didn't even talk about, but minoxidil was originally a blood pressure medication. So this is why it carries some of those cardiovascular side effects or cardiovascular risk factors. So there's people drinking minoxidil, liquid minoxidil, and having palpitations, going to ERs, and I would strongly encourage people not to do that. If enough people do that, wind up in ERs, they may make it a prescription drug again because people
would not be
can't
surprising
be
to see.
Yeah.
Of note, minoxidil can increase prolactin, and yes, your sulfosyltransferase polymorphism or the activity of that enzyme does very likely affect response. So some people get that checked. Tretinoin can potentially help with that. But I think that's a good summary of minoxidil. Some people also ask, do I lose all of the progress that I gained on minoxidil after taking it for 5 or 10 years and having a good response? If I were to stop it, do I lose every bit of that?
Yeah, and that's a good question. And you probably do lose most of that progress in terms of the actual 20 or 30% volume increase that you get. There's a small chance that minoxidil may be playing a role in type 1 collagen deposition. So you have this type 1 collagen that gets inappropriately deposited, that formation it's kind of dysregulated, and you get this scalp fibrosis in some of the more severe cases of androgenic alopecia. There's some thought that since minoxidil disrupts collagen production, and this is in vitro, so we don't know if this is happening in somebody who's had a scalp biopsy would really be the only way to see this. But some of the in vitro data supports that, and it's thought, oh, maybe this is part of the positive effect. Maybe there is a little bit of a prolonging of putting off the hair loss, and you do get more blood flow. And more blood flow, I think, probably has a small effect, but I don't think that you're going to buy yourself permanent ground on the minoxidil, and a lot of that volume increase is dependent upon being on the medication. So we talked about mechanism, the medication. As far as the oral doses, basically whatever the minimum effective dose someone needs is where I'm starting. We're certainly not starting off with 5 milligrams to give people lots of side effects and anxiety. So a smart taper up depending on the patient and depending on the degree of alopecia that they have. So where are they at on that Norwood scale? And we talked about long-term study findings. The most important thing here from this paper is that even 5 years after starting the 2 or 3% minoxidil, these people were still above their baseline. So, that's what a lot of people are thinking. It's like, well, maybe they plan to get a hair transplant long-term. They just need to buy themselves some time. And if let's say the average person starts using topical minoxidil today, they're consistent with it. 5 years from now, they're going to have more hair than they did today. Now, this isn't true for everybody. Somebody's going to comment and say, I used topical minoxidil and I've lost hair and lost ground, and I believe them because there's a lot of individual variation, and this is really a high-level look at averages across populations. And there's some specific populations that have some limitations we'll talk about on this next slide. But as far as effectiveness, what would we give minoxidil? Oral minoxidil or topical minoxidil? Are they equivalent? What would we say on our Norwood scale?
I would give both of them an equivalent rating of Norwood 1.
Norwood 1.
Yeah, maybe a 2, depending on the dose.
Yeah, we're still looking for that secret juice to be a Norwood 0, the elusive Norwood 0 rating.
Yes.
So I think that's a pretty good overview of minoxidil. If people have questions, feel free to leave those there. Moving over to another medication, we'll just chat about the 5-alpha reductase inhibitors. So this is Dutasteride and Finasteride that we mentioned from that first study. And these are, Finasteride is by far more popular, but these medications were another serendipitous discovery, just like minoxidil. We just happened upon these things by accident, and they're typically used in treating enlarged prostate, slowing progression of prostate cancer now in urology.
Common.
And then also lower doses being used on label with finasteride for hair loss, and then off label. A lot of people are starting to prescribe Dutasteride because of some of this data that's come out showing, hey, it is more effective, which is somewhat predictable because you see less scalp DHT and lower serum DHT with the Dutasteride.
Yeah. So Dutasteride is more effective and it has less sequela and less side effects. There is a solid amount of clinical evidence that shows both. So why not just use it all the time?
Yeah, I should probably just switch all of my patients doing well on finasteride over to another drug because it's more effective, right?
Yeah. The half-life of Dutasteride can certainly be a downside, especially if there's fertility for both males and females that is desired anytime soon, especially for people on oral Dutasteride. We got a lot of questions about this, so we've done a post about it, and I think we've already talked about it another time as well. But the half-life of Dutasteride is kind of like Tylenol or even aspirin, where the first bit of it is metabolized very quickly, so it has a biphasic or a bimodal pharmacokinetic profile. And then the next part of it's metabolized very slowly. So that's why if you Google it, it'll say 5 weeks. But if you take an extremely small dose, it will be metabolized fairly fast. So that's kind of both a strength and a weakness of it.
Yeah, and that being said, I mean, Dutasteride at about 0.1 milligrams, I believe was the study.
Yep.
And these are specially formulated gel caps. I don't believe at this time that the dry capsules that some compounding pharmacies are making are as effective. I mean, if I see blood work, I may be open to change my mind. I haven't seen that evidence yet. But that 0.1 milligram of Dutasteride is just about as effective, a little bit more so even than the standard 1 milligram per day of finasteride. And, 0.5 is pretty standard. Some people are taking 0.5 milligrams of Dutasteride once per week. And when I'm individualizing the dose here, I'm really looking at, how aggressive does somebody want to be? People have different preferences. And then how aggressive is their androgenic alopecia that they're kind of fighting against? If it's very mild, it's just a preventive thing, like you can get by with a lot less early on. Just like, recurring theme in preventive medicine, it's much easier to make these changes early. And if you're intervening in the late stages, have to be much more aggressive.
Yeah, the law of diminishing returns applies. So getting your maximum return with minimal side effect over a long period of time, especially with androgenic alopecia, that's a good segue into starting 5-alpha reductase inhibitors at different Norwood scores.
Yeah, speaking of over a long period of time, this is the study that I found that has the longest follow-up period with actual objective data points. So this was in a cohort of the Japanese population, Japanese men with androgenic alopecia. And in the men who started on finasteride, standard 1 milligram per day in this study, they continued to see improvement all the way up to about 8 or 9 years after starting the medication. And if you're on the opposite end of the spectrum there, you're Norwood 6, Norwood 7, you see improvement for about the first year, maybe the first 2 years. It's a more modest improvement in terms of probably the relative percent increase in hair density. And then it starts to slowly sort of taper off and it kind of stabilizes. And we'll put this graphic up for people to see. But if you're looking at like Norwood 1, 2, 3, they seem to respond very well and, up to about 5-6 years out on average. So I thought that was really impressive. And, one of the things to think of here is, the length of a hair follicle cycle. So, we know that the length that women are able to grow their hair, that kind of lines up with, okay, you're looking at anagen, like a growth phase, right? And we know that's not just going to be like, 6 months. You can't grow out, 20 inches of hair in 6 months or 12 months even. So the hair follicle cycle should be longer whenever you have inflammatory conditions or a lot of DHT floating around. It's just going to be shorter. That's one of the reasons that most men can't grow like Fabio style hair. They just don't have that long of an anagen window to do so. Will end up looking kind of stringy and not the look that most people are going for. So I just thought that was interesting. And this is basically looking at early intervention, and what your, I don't want to say your, because this is a specific, ethnic background, but I think the same principle could probably be applied where you are intervening early, just as you alluded to, and then you're just going to have a better outcome. And I think this is really promising for people who have maybe started and thought that their progress has plateaued after a year, 2 years, that, even for the next 5 years, you could see progress on some sort of a 5-alpha reductase inhibitor.
Yeah, and if anybody has their own personal anecdotes with this, please let us know. We'll see if there's been anybody on the 5-alpha reductase inhibitor for longer than this study. I've many patients that certainly have been, with some really amazing responses given their genetic predispositions. So, and also let us know how long you're able to grow your hair, and perhaps we will as well. So, yeah, that's a good summary of the study. Another takeaway that I get from this is if you're a Norwood 4 or lower, then things look quite good for like long-term use. Whereas if you're not in that, if you're able to get a hair transplant, then unless you're planning to become a just shave it bro, then perhaps you do consider like a hair transplant if possible, or even shaving. But whatever result that you would get within the first 2 or so years, maybe 3 years, is not going to get any better from this treatment and therapy.
Yeah, I think it's a good way to kind of stratify you and build out your long-term plans, because some people are like, well, right now I'm not in a financial position to get a hair transplant, but 5 years, 10 years from now, that could be very different. And kind of looking at where you fall on this chart can be very helpful. So we mentioned earlier, you mentioned there's, I know there's a handful of studies that show Dutasteride causes less side effects than Finasteride. And this is kind of bizarre to me. It's not incredibly well understood. I know there's some preclinical data supporting a neuroprotective effect and anti-inflammatory effect with Dutasteride, but what's your theory as to why Dutasteride would seem to cause less side effects, even though it is a more potent medication on paper, lowering DHT more in the serum, scalp, presumably everywhere?
Yeah. It's important to understand that the usual dosing of Dutasteride for BPH is generally 0.5 milligrams every single day. And that is not really a comparable dose to even 5 milligrams of Finasteride, for many reasons, but the main reason being that it inhibits all 3 isoenzymes of 5-alpha reductase. And on paper, you would think that this would be a detriment to Dutasteride because your serum DHT is more likely to go lower. However, there is several papers, many different, I suppose, correlation, but not causation, of there not being, of post-Dutasteride syndrome or Dutasteride side effects being much more rare in eugonadal individuals. And my theory behind this is, if you look at the 3 different isoenzymes, the concentration in different cells, specifically the intrachronology of it, as Dr. Fernand Labrie would say, you look at the DHT in each of those buckets. So pretend that you have 3 different buckets here, and then the serum is just the pipe that connects them. So you're not as much worried about the level of DHT in the pipe that connects them, but the level of DHT in all 3 buckets. So let's say you're on an equitable dose, maybe 0.5 Dutasteride once a week, maybe twice a week, and 1 milligram of Finasteride a day. Your serum DHT decreases 65%. So the DHT in the pipe is equally lower, but the DHT in your genital skin is much lower. The DHT in your non-genital skin is much higher in Finasteride. Say that this one's almost completely empty and this one's almost completely full in Finasteride. That's going to make it much more difficult for your body's many negative and positive feedback inhibitions to alter things like androgen receptor density, or even 5-alpha reductase activity. But with Dutasteride, you have relatively equal amounts. So let's say that all the buckets are halfway full. So it's an easier thing for your body to self-regulate. In addition to that, you're going to be able to take a lower dose and get a better response while affecting the type of 5-alpha reductase that's in the liver. There's actually 2 types. That's going to be converting your progestogenic neurosteroids. So there's a lot of different reasons why Dutasteride is generally better tolerated, and that's just my theory on why it is. And anecdotally, we have certainly seen this as well.
Yeah, and this reminds me of the dopamine wave pool, except now there are 3 wave pools, or I suppose you could think of it as you have 3 hot springs, and Dutasteride will keep all of those at the same temperature.
Yep.
But if you're taking Finasteride, maybe 2 of those are lukewarm, and 1 is freezing cold, and that's your genital skin that's freezing cold. And we know that the body does adapt. Like, dopamine is a hormone. I know some people don't think of it that way, but it is. It's a neurotransmitter hormone, and your body does rebalance when you have high levels or low levels. So, I can imagine a situation like just like a tri-level home, you're not going to have the same temperature in each of those zones, corresponding with the 3, subtypes of the 3 isoforms of 5-alpha reductase and then the subsequent tissue expression. So I think it's a really interesting theory, and it seems to match some anecdotal data. But I don't think we're quite scientists, can't say for sure, but it's one of the more compelling things that I've heard that you and I have talked extensively about too. So to talk about side effects, because we kind of mentioned there are side effects, but what do those things look like? I think that's the last point that we wanted to make about the 5-alpha reductase inhibitors. What should people watch for, or what is common, and who's more likely to get side effects?
Mm-hmm. So there's both negative and positive side effects. For example, for Dutasteride, potentially preventing left ventricular hypertrophy, or LVH, would be one of the side effects if that's something that an individual is prone to. But other side effects, especially of Dutasteride, basically mimic hypogonadism and mimic postpartum psychosis and postpartum depression. So postpartum psychosis and depression is related to a sharp decrease in what I call the progestogen pool: pregnenolone, progesterone, DHP, and THP. And we treat this with IV THP for severe cases of postpartum depression, psychosis, suicidal ideation, etc. And it is possibly something that can be utilized with 5-alpha reductase inhibitors like DHP and or THP in the future. But you don't want to just get on a prescribing cascade. In addition to that, kind of like the Finasteride side effect spectrum, we describe as an x-axis and a y-axis. One axis is more genitourinary side effects. One axis is more neurologic side effects, which can include an imbalance in sympathetic and parasympathetic drive, like fight or flight, rest and digest. And then it can also include things like, we just mentioned them, postpartum psychosis, anxiety, depression, etc. So that's the way that we see it, and that's the way that we kind of treat all of those things on an individual basis, where there's not one specific regimen.
Yeah, and I think it's important to note that earlier, well, I say this year, it was actually 2022, I believe, when the FDA has placed a warning label on Finasteride for suicidal ideation, just due to the post-marketing attempts and people in the advocacy groups for post-Finasteride syndrome.
Yep. It is very important to realize the potential side effects of any medication, including Finasteride, including Dutasteride, including testosterone. But knowing that many people take these medications and have noticeable side effects. Some people take the medications and have unnoticeable side effects. And some people do take the medications, perhaps they're a good candidate for it, and they truly do not have any side effect. So there's people in all 3 groups, and kind of like skewing opinion to where everybody has side effects on Finasteride or nobody's side effects on Finasteride is just kind of an example of anecdotal and observer bias. Well, I suppose we should rate these medications on the Norwood scale as well. What do we rate Finasteride and Dutasteride?
I give Finasteride a Norwood 1. I give Dutasteride a mature hairline.
That sounds pretty good to me. I would rate them the same.
All right. So next up we have topical Finasteride, topical Dutasteride. So these are medications we get a lot of questions about, and of course there's less data because it's a novel formulation of a pre-existing medication. And people ask us, well, if I take Finasteride, will my DHT, not be affected? Or if I take topical Dutasteride, does that go systemic? And we have some pretty clear data that topical Finasteride does in fact go systemic. I don't know that this was well known, initially, but now it seems to be understood. And I think there is something to it where there's less likely to be side effects from finasteride. And my theory behind this is with the topical, you're bypassing the first pass effect through the liver, where you're going to kick out a ton of drug metabolites that we don't know as much about. I mean, they really aren't studied as well. I know in like the mental health sphere, some of the active metabolites of the drugs are actually the ones that have the therapeutic effects, and there's some things known there. But with topical finasteride, I don't know what a metabolite of finasteride would be. I don't know if it's been studied. So if you're bypassing that and you're using it topically, then presumably you're going to have less of that happening. So that may be a plausible reason for why we see less side effects with a topical formulation. This study tells us that it looks like in this case, the topical actually was able to lower DHT a little bit more than the oral. I haven't seen that reproduced. The other study I saw using topical showed about 48%, I think was the highest dose group, and that was a 48% reduction in serum DHT. And you still had positive changes in hair growth, vellus hairs, terminal hairs. Typically, the pattern you want to see is less vellus hairs, which are the very fine hairs that look like baby hairs, is what we call them, and more of the terminal hairs, which are what you think of as your normal hair that's on top of your head.
Yeah. Topical finasteride is certainly not useless just because it goes systemic. Another theory is back to the hot springs analogies. Instead of changing that very, very quickly, the temperature of the springs may change a little bit more slowly, like the frog in a pot that slowly boils. Perhaps that has something to do with it as well. We get a lot of questions regarding, so we kind of asked the two questions. Does topical finasteride go systemic? Yes. Does it work? Yes. Does topical dutasteride go systemic? Yes. Even though it's right around the size that sometimes they don't go systemic, it's a very lipophilic molecule. And again, this is not extremely well studied. Both topical dutasteride solution and topical dutasteride mesotherapy, which is injections, those are two different things that require two different dosings. But depending on the dose, depending on the person, depending on the thinness of the skin, depending on the lipophilicity of the skin, depending on how many scales and scabs and scratches and microneedling is going on as well, a different dose might need changed, or a different dosing protocol might need utilized. But in many cases of the hundreds of patients that we've had on topicals, for topical dutasteride, it is very common to see serum DHT not affected. However, it does go systemic. It is likely just metabolized very quickly. So, and we already talked about the half-life of dutasteride, so we don't need to go over that again.
Yeah, and there is an interesting point in one of these studies of topical dutasteride. It's one of the only studies that has a lot of free access data. And unfortunately, the topical dutasteride is not isolated. It's mixed into the secret juice that I believe New Hair is the company name. But in their data, it points to the patients admittedly only using the product 2 to 3 times per week. But despite this, they still had improvements in hair growth parameters that they were targeting. So, is this because they were using multiple vectors, or is this because dutasteride has a longer half-life? The authors speculate it's because dutasteride has a longer half-life, and they call it a 28-hour half-life. I don't know where this data comes from. There's not a citation next to it. So either they just kind of made it up, or maybe they did the groundwork and did some, in vitro research on, scalp skin and seeing how long it takes to clear the DHT. I don't really know, but 28 hours is the number that they picked, and it probably does last longer than something like a finasteride in the scalp if it's just following the standard pharmacology modeling.
By the way, as mentioned, we did post specifically about dutasteride half-lives with various sources, and the inflection point to where it changes from a fast order pharmacokinetic profile to slow is around a dose of 0.1 milligram orally. So that is likely different topically. And again, I don't think it's been studied. We haven't seen a study. Please send us the study link or PubMed ID if you have.
Yeah, that would be fantastic. So now we are on, let's see, we talked about topical finasteride. Oh, this was an interesting thing. This is another topical finasteride. This was I guess, theory or an idea that the authors of this study came up with. They thought that, well, if topical finasteride does not build up as much as systemic, like oral finasteride does, then maybe pregnant women can use this. And I don't think that that's a particularly great idea, given the link from finasteride to male genital birth defects. I would be even skeptical of the risk-benefit ratio for a topical retinoid during pregnancy. But they make the case that, well, topical retinoids are class C, systemic retinoids like, isotretinoin are class X for pregnancy. So maybe topical finasteride could be class C. I don't know where this idea came up with, but I advise against topical finasteride and topical dutasteride for pregnant women, and oral for that matter.
Yep.
And the topical, even for the partners of those women when they're planning to become pregnant or while they're pregnant.
Yep. And for the record, I also advise against topical tretinoin for pregnant ladies, out of an abundance of caution, but it just makes sense. And then as far as like time periods in general, stopping finasteride at least 90 days before planning conception, spermatogenesis taking 60 days, and then stopping dutasteride between 6 and 12 months before, depending on what dose you're on and depending on what method of administration.
Yeah, and it's probably reasonable for people to check fertility parameters with dutasteride, because we know 3 to 6 months after taking dutasteride, you're still going to have, I believe it was 20 to 30% lower semen volume and sperm count. So, those metrics can be affected not just in the immediate time period you're taking the medication. So, one of those considerations of why dutasteride isn't a great choice for every single patient.
Yep.
All right. And next we have, this is one we've got a lot of questions about. Let me make sure we haven't skipped over. Yep, let's go there. So, Latanoprost. I'm sorry, this is Ketoconazole. So,
we get lots of questions about both.
So, Ketoconazole, what is it? It's a it's an antifungal medication. So why are we putting this on top of our heads? Like, I don't have fungus up there, do I?
Yeah, it's an azole. I believe it's an ergosterol synthase inhibitor, but it has a couple different mechanisms of action. It can be an anti-androgen in that competitive inhibition at the androgen receptor. And then also in the past, I believe we mentioned its benefits with as an antibacterial and an antifungal. So subclinical infections of both. And it's well tolerated. It can help volumize the hair as well, but it can also make it frizzy.
Yeah, and the studies have been done with 2%, but there are now a ton of people using 1% over the counter, the Nizoral brand, which I just learned from you last week that not all Nizoral is actually containing ketoconazole. So that's
infuriating.
It is, but it's a pro tip for anybody out there listening who has Nizoral. Make sure that you're actually getting the medication that you want from that. So 2% ketoconazole, and you really want to be leaving this on your scalp for 5, probably 10 minutes is even better, so that you have more absorption into the skin and potentially more of that competitive binding of the androgen receptor. Now, is it going to outcompete every single piece of DHT there? Is it going to bind that strongly? I don't think so, but it does have an effect size, and I think it's a useful adjunct. It doesn't take any more time. The prescription medication is incredibly cheap. It's only a few dollars for a bottle of the shampoo. Yep. It might be cheaper than the shampoo you're using right now.
Yep.
So I think it's a good option for people as an adjunct, but I don't think it's the foundation of anybody's hair loss prevention protocol. But it can certainly be useful as an adjunct.
Yep. I think most people put it on for 10 to 15 minutes. That way you let it soak into the scalp a bit. And most people do not do this every day. Some people do. But I know if I do it every day, then I get incredibly frizzy hair. So I try not to do it too often. There is a product that I use that's combined with topical caffeine that we can briefly touch on. Also topical anti-androgen. Talked about it with Huberman. We've got a lot of questions about it. But it's just another topical anti-androgen, kind of like ketoconazole. Again, low risk, likely clinically significant benefit. So why not add it in? I use a product that has ketoconazole and topical caffeine and actually essential oil of peppermint oil. I love the smell. That's the Intelligent Shop shampoo, but there's a lot of different good ones. If you want to get your most bang for the buck, probably the biggest bang for the buck is just the prescription 2% ketoconazole.
Yeah, I would have to agree. And while we're on the topic of the ketoconazole and 2%, here's study findings. So this first picture here is actually the Minoxidil group. So this was actually female pattern hair loss. There's not a ton of data specifically looking at this as an isolated variable in androgenic alopecia, but in female pattern hair loss, it's apparent that androgens do play some role, or at least ketoconazole has some positive effect. So this is Minoxidil. This is a pretty impressive recovery here. And this is only after 6 months. So from photo A to photo D, you're looking at 6 months. And then if you go down to the ketoconazole, you see a pretty impressive recovery as well. Now, this obviously isn't the same person.
Yep.
I don't think their hair loss was as severe at baseline, but you see clear improvements over 6 months. And this wasn't a telogen effluvium. This is female pattern hair loss, which androgens are involved in to some degree. So it's reassuring to see some progress like that. Say, hey, this actually is an effective treatment. And I personally really like it when the authors include these photographs in their studies, because a lot of the information, like Latanoprost we talked about, a lot of times these studies are just saying hair increased in thickness and density. And I have no clue if that's 1 more hair per square centimeter or 50 more hairs per square centimeter.
Yeah, including the objective data is very important, especially because hopefully someday all these will be included in more meta-analyses and systematic reviews. Another thing we love to see, as Alec, again, our friend Alec McCarthy loves to emphasize, histopath, so scalp biopsies, and also, if possible, skin microbiome testing. Doris Day likes to emphasize that as well. It would be very interesting to see if people have subclinical infections of bacteria or fungi that respond well to ketoconazole. So eventually we will know that. Those scientists out there, please study it.
Yeah, I've seen some theories where people may be topically applying probiotics or using a probiotic shampoo to create a more, or I guess, a less hostile scalp microbiome for hair loss. I don't think it's beyond the realm of possibility that it could be an adjunct. So, a lot of very exciting things going on out there. So Latanoprost, I guess we can chat about that just a bit. So this is a prostaglandin analog. Was this one another serendipitous discovery? Because I want to say that I remember it that way. So this is, an eye drop that's used to decrease intraocular pressure in glaucoma. And then, we see, particularly women are probably the ones that notice this, that their eyelashes are becoming long and luscious. And then from there, we had the development of things like Latisse, which is, there's Latanoprost, Metaprost that are compounded into some of these topical hair loss solutions now. And these are the studies that they don't have the objective in data points. We just know that they do lead to some improvement. So you have less vellus hairs, more terminal hairs, and then you have an increase in density and coverage and thickness and those sorts of metrics. So I don't know how potent they are, but they do work. And if you're using a fancy compounded topical and you're using a growth agonist as well, then why not add in Latanoprost? Could there possibly be any downside?
There certainly could be. So with Latanoprost, there is potentially, I believe, a blood pressure change that could be affected. And then you can also spill it in other areas, other skin areas, and grow hair in other areas that is not where you do not want to grow hair at. So that's kind of, I believe it's well known for Latisse. So you want to be very careful if your topical solution includes Latanoprost. I was going to mention another serendipitous discovery was with sildenafil or Viagra, which I believe was also originally a blood pressure medication. But they noticed, first they noticed sexual health changes as well, easier erections. But they also noticed growth of eyebrow hair. And occasionally, if someone is at risk of like in-tissue hypoxia or whatnot, then perhaps a low dose of tadalafil is a better choice than sildenafil. But oddly enough, sildenafil, which has a much shorter half-life, was found to grow thicker, bushier eyebrow hair.
Yeah, that's interesting. So are you suggesting that there is erectile tissue in the eyebrows, or that it's just improving blood flow and nourishing those hair follicles better?
Just the latter.
Just the latter. Yeah. So I think that's enough about the Latanoprost. Let's see. We talked about caffeine a bit. Do we need to dive into, why that works, or what people might expect from that? Because this is another one where I've seen, people applying a caffeine solution, and it leads to those sort of non-specific effects, but a general improvement in like hair growth and hair quality.
Yeah, probably to some degree a topical anti-androgen. It may also have other anti-inflammatory effects. It kind of goes back to the theories behind how much of hair loss is inflammatory related. Yes, if you do a scalp biopsy in an area that has androgenic alopecia, you'll certainly see like scar tissue and type 1 collagen, as you mentioned, and inflammation. But is that the chicken or the egg or somewhere in between? Probably somewhere in between.
Yeah. So how do we rank these things? We have, let's say, caffeine, Latanoprost, Ketoconazole, 2% shampoo. How many Norwoods are these medications getting?
For all of them except Ketoconazole, Norwood 4. Maybe a Norwood 3. For Ketoconazole, I would give it a Norwood 2, but mostly just because some people are particularly good candidates for it.
Yeah, I like that. So Norwood 2 for 2% Ketoconazole. And on the topic of inflammation, what about these low potency corticosteroids that are being added into these solutions sometimes? I had a really hard time finding anything relating specifically to androgenic alopecia.
Yep.
And that's because we have a lot of like alopecia areata and other conditions that respond well to corticosteroids. So it makes it really hard to find those results. There may be a study out there, but I certainly wasn't able to come across it. But with the inflammatory response that's seen in androgenic alopecia, clearly correcting that inflammation is going to have some effect. Is a long-term use of a corticosteroid the right choice? I suspect probably not.
Probably not.
But if I'm putting this okay, what is the right patient for this? It's someone who is clearly has an inflamed scalp. They're like
psoriasis.
They have some other
Eczema.
atopic diseases, exactly, like psoriasis, asthma. And then they may even have some people, they'll notice when they go on like Finasteride or Dutasteride, it's like, oh yeah, I used to be always itching my scalp, and I'm not doing that. I used to have really oily hair, and I'm not doing that. So maybe for those patients at the beginning of their plan, a couple months of a topical corticosteroid might have a small effect, but it's not something I'd want people on long term, just because there are negative effects on skin health when you're applying a corticosteroid long term. And if you're applying a corticosteroid, it's going to be like fertilizer for a fungus that's growing there. So you might end up needing that ketoconazole.
Yeah, that's quite likely. That's one thing that I've changed in my practice is stopping long-term corticosteroid adjuncts or compounds in with other medications. It also, it's well known that corticosteroids, especially at higher potency, can thin the skin. And I believe it also would increase the risk of absorption for topical Dutasteride. So probably a lot of reasons to avoid long-term use. But that being said, we have seen some phenomenal results of people who, when they first go on a hair loss prevention regimen, incorporating a corticosteroid.
Yeah, and I think part of this is now there's a lot more options available. Like people aren't just compounding the kitchen sink, because you would have 6 or 7 ingredients, and these pharmacies would just add in a steroid there because helps hair growth, decreases inflammation. And now I think it's starting to get a little bit more refined. So it's really good to have more options and really being able to pick exactly what formulation you want for a given patient. So I say we give topical corticosteroids for the non-autoimmune hair loss a Norwood 4.
Agreed.
So let's talk about microneedling. I guess we can talk about derma rolling too. We can talk about the stamps. I've seen some of those devices out there. There's all sorts of ways that people are poking holes in their head to
Laser.
to try and damage the scalp, stimulate healing, and grow some hair. So, what is the science behind this, and does it work?
Yeah, so there's a couple different benefits of microneedling. One is it can be used as a delivery mechanism for things like neuromodulator that we discussed earlier. Another thing is if it gets deep enough, and even if you have a thin scalp, probably at least 1 millimeter, talk to your healthcare provider, of course, but maybe up to 1.5 millimeters wouldn't be that unusual. It's going to help stimulate normal collagen synthesis and growth, and also blood flow. So there's a lot of different benefits to microneedling. The other theory behind it is any damage is also going to recruit things like fibroblasts, growth factors. It's going to make more leaky capillaries. Well, obviously leaky capillaries, if you notice that you're having pinprick bleeding. And when you have those leaky capillaries, what's leaking? Plasma. That happens to be essentially platelet-rich plasma. So you're leaking your own platelet-rich plasma across your scalp as you microneedle. Not to get too off onto a tangent, but that's likely why it works kind of similarly to platelet-rich plasma. It can be kind of a pain to do so, and the frequency is something that's often discussed and not exactly well characterized. What is the optimal frequency at this point?
Yeah, I believe most of the literature is using 1.5 millimeter, and the data that I've seen doesn't suggest to the point of bleeding, but to scalp erythema, which means scalp redness. So the skin is definitely not going to be comfortable. It's not like a scalp massage.
Nope.
But do you have to use 1.5 millimeters to get there? I don't think so, because there's a large variation in scalp thickness,
Yes.
just like you mentioned. So when we're looking at the data with microneedling, it's like, I was kind of surprised to see the magnitude at which this increased hair count. So this is just, one of the papers that we found here, but this was 12 weeks, which is very quick, right? So that's 3 months, less than 3 months.
Mm-hmm.
And people were using Minoxidil or using Minoxidil plus microneedling. And Minoxidil alone, you probably at the 3-month mark, you're seeing about a 20% increase in volume. In this study, that correlated to about 22 more hairs per square centimeter. And then whenever they added in microneedling, they saw an increase of 91.4 more hairs per square centimeter. And to put this in context, now we may have mentioned this at the beginning of the show. If we didn't, I apologize, but the average number of hairs that somebody has per square centimeter is 124 to 200. So if you're adding 91 more hairs back into that square centimeter, that's a really robust result. That's going to be at least 40, if not 50% increase in density, depending on where somebody's starting from.
Yeah, this was a particularly fantastic result. So even if it was half that much, then it would be certainly worth it to consider microneedling, I suppose, especially if you're on Minoxidil. The vehicle group here, I believe, was Minoxidil only.
Yeah, but they compared it to the Minoxidil. So, even microneedling without Minoxidil, for those that don't tolerate it, still has some benefit for all the things that you mentioned at the outset, as far as stimulating those sort of regenerative processes, which can be kind of a tricky word when we're talking about like the PRP-like properties. But basically, I would put it in the bucket that I've started using of like, helping to prevent system decline. So like thinking of your scalp skin as a body system, and then preventing that from declining in function. And its function in this case, in addition to being like the skin barrier, growing hair.
Yep. We love to talk about things that you can stack with microneedling other than Minoxidil. Various peptides, not in all formulations, so likely not a foam if you're microneedling. You want things that are not going to cause an infection or irritation of the skin. So, but several peptides that are kind of like growth agonists, for example, GHK copper peptide or BPC-157 would be interesting. And then a neuromodulator that's a small enough particle size to go in as well. Those things would likely be something that would be done at your doctor's office.
Yeah, and that's one of those things, like there's a ton of companies that sell, hair loss peptides and GHK. It's used in cosmetics all the time over the counter. But I haven't seen particularly robust results when people have been using this. But I also haven't seen people use like pharmacy grade, higher potency GHK, pair that with, microneedling specifically, because you're just going to have better absorption. I mean, you'll have better absorption of your, vitamin C serum for your face if you're using a little bit of microneedling to drive that in, or even if you're doing that beforehand. The vitamin C is going to burn like alcohol probably, but that doesn't necessarily mean it's causing an inflammatory reaction there.
Yep.
So I think those are really interesting things that people probably haven't heard before. So what would we give microneedling in terms of effectiveness? Is it on the Norwood scale, what are we looking at?
Yeah, it's a Norwood 1.
Yeah, it's pretty effective.
By the way, on that topic, a lot of people talk about the big three for hair loss. And microneedling is likely one of the big three for hair loss. It used to be Ketoconazole, Minoxidil, and Finasteride. But perhaps it's that big three is kind of morphing. Maybe you add it into a big five, you add in Dutasteride, you add in microneedling.
Yeah, so perhaps we could see a rearrangement where now the big three is Dutasteride, microneedling, and Minoxidil.
Yeah.
So there's a new champion.
I agree.
All right, and going back to inflammation a little bit, there was a study that came out last year about N-acetylcysteine. And when I think about that, I think about the increase in the serum glutathione that you can get from giving NAC, which is in that interesting category of both a medication and a supplement. And hopefully that's where NMN lands. I know there's a lot of people who have been talking about this and asking me about this, and I really don't know exactly what direction it's going. But as an aside, anyway, N-acetylcysteine was found to give us a non-specific endpoint, but a general improvement in hair count. And N-acetylcysteine has been used in other hair loss treatments, not for androgenic alopecia, but for trichotillomania, where people are kind of have this under the umbrella of OCD tendency to kind of pick and pull and damage their hair. And it's been shown to be effective for that, as well as some other sort of OCD type behaviors. Some people will take N-acetylcysteine and kind of have a dysphoric reaction to that, which I think is kind of interesting. And maybe they do like their kind of like organization and their methodical way of doing things, and the N-acetylcysteine will kind of disrupt that homeostasis that they have that's actually serving them well. So I think that may account for some of the side effects. So there can be side effects even with something as benign as something that increases your glutathione levels. But the dose for this was 600 milligrams 3 times per day. So I don't know exactly what the adherence looked like in the study. Most people are not going to take something 3 times a day, but you could probably still do 1,200 milligrams once per day and have some effect size, because that's going to increase glutathione as well. So I think this was really interesting and kind of highlights, when we were talking about topical corticosteroids, really maybe throwing in some N-acetylcysteine at the beginning of the treatment instead of a topical corticosteroid, makes a lot of sense as we're sitting down and kind of reviewing all the data now. So I think that's something for people to consider, because it's generally very well tolerated. Doesn't smell particularly good. So if people buy N-acetylcysteine and they're opening up and they smell sulfur, rotten eggs, that's to be expected. You didn't get a rotten batch.
Yeah, I would give N-acetylcysteine a Norwood 3, partly because perhaps it would benefit someone for a different health reason as well. And then their hair will kind of benefit secondarily to that.
Yeah, it's a good way to look at it. I love the 2 birds, 1 stone scenarios that we run into on occasion. So heading over to another one medication we get asked about a lot is topical tretinoin. So we kind of touched on this earlier. We're talking about topical retinoids, which tretinoin is one. I don't know if there's any specific data on brand name Differin or Adapalene on androgenic alopecia, but they have a similar effect, essentially, when you're looking at skin wrinkles, skin aging, and things like that. It tends to be a little bit less irritating when we're talking about the Adapalene. But tretinoin has been used in a number of trials, improving the efficacy of Minoxidil, and also in this study was used alone and even stimulated some hair growth when it was used as just an isolated treatment, so a standalone, versus just being something that's an adjunct. So I thought that was particularly interesting.
Mm-hmm.
And the one thing I highlighted here was one female subject with pronounced alopecia for more than 20 years had regrowth of hair using only tretinoin over a period of 18 months. So we found a hyper responder to tretinoin. So this is where you get into sort of, the precision genetics of hair loss. And, people will do things like the tricho test, and there's a number of S&Ps. And actually, 23andMe will tell you about some of these when you're looking at the data, like net, are you, at risk for hair loss or not? And there's ways that these medications are more or less likely to help you. And I think we touched on that a bit in the first half of the episode. But I think tretinoin is really interesting. The potential downside there is, scalp irritation. Personally, I can't even use tretinoin consistently for my face because of the skin redness, the irritation, and flaking. Perhaps that's because I've started too high of a concentration, or because I haven't used it through and gone through the shedding phase. But for me, I just prefer to use the adapalene because I can use that and I don't experience those side effects. So what would you add to the discussion of tretinoin? Is it for everybody? Obviously not pregnant women, as we talked about earlier, but who do you think benefits the most, and any idea why one person would be a hyper responder to tretinoin like this?
People with especially oily scalps and skin would likely benefit more. As far as a hyper responder, I suppose you could say that someone that concurrently struggles with androgenic acne could be a slightly better candidate. So perhaps people with PCOS are obviously androgenic acne. On that note, if they hyper-responded to tretinoin, perhaps they would hyper-respond to something like clascoterone as well. So I guess for that reason, I give tretinoin a Norwood 3.
Yeah, Norwood 3 for tretinoin makes sense. Clascoterone's an interesting agent. I think it's being evaluated in androgenic alopecia, but it's actually already out for hormonal acne, which is a really broad term if you think about everything that's considered a hormone.
Yeah, there's not really acne that's hormonal and not hormonal. That's one of the main reasons why it's actually not it works. It has good enough efficacy to get FDA approval, and we do use it from time to time. But if you have jawline acne, often it is not going to improve it all the way, because most of the time it's multifactorial. Yep. And that's probably something that you don't need a genetic test to take. That's why in general, you consider the oiliness of the skin, what drying agent you need, usually in the form of a topical retinoid, and if there is a bacterial component as well, or another component. So for example, diet has a huge effect on acne, not just because it's modulation of IGF-1, but also because of other effects. An interesting thing about sebaceous glands is even DHEA, which is generally considered the pawn on the chessboard of hormones, a very weak androgen. I believe it's in sebaceous glands, where in females, almost 50% of DHEA is quickly converted to DHT. So in those cases, perhaps the topical Dutasteride would actually work fairly well if it gets into the sebaceous gland. Not to go off on a rabbit trail too much, that just goes to show that just like androgenic alopecia or even other types of alopecia, there's most commonly more than one factor at play. Another kind of like rule of thumb you can ask yourself is, well, let's say you do all the evaluations and none of the genetics look like this individual is prone to androgenic alopecia whatsoever. But if they're a male and they have like eugonadal levels of male hormones systemically, they are just going to be much more likely just because of that compared to a female with the same presentation.
Absolutely. And I was going to say there, if you have all the genetics in front of you and the clinical picture doesn't match, does that just mean that the patient is lying to you?
Yeah, obviously not.
Yeah. So, I mean, you have to laugh about some of these things sometimes and use, common sense when you have the clinical picture that doesn't match up, because, I mean, lab errors they do happen. So I've heard you talk about this before, women, birth control and the different, I think there's 4 generations now of oral contraceptives. So some women, I guess girls at this point, whenever they start having, irregular periods or acne or thinning hair. They get put on an oral contraceptive, and that seems to solve a lot of problems. And they're not always a terrible intervention. But what are some of the underlying reasons for that? It's always fun to dive a little bit deeper and say, okay, well, this has these effects, but why is that? And talking about why things may be different when you have different types of estrogens and then different types of progestins as well.
Mm-hmm. So this is one of the conversations that I particularly love. Sometimes I joke and I say that I wish that patients were as picky about their compound selection for their synthetic estrogen and their synthetic progestin as many men are for their compound selection of their synthetic androgen. So just like synthetic androgens, the fitness community loves, and we actually love talking about different pharmacodynamic effects, interactions with aromatase, interactions with glucocorticoid receptors. Does this compound aromatize? Is its aromatized product active? We love talking about the same exact thing with oral contraceptives. So there's combined oral contraceptives, which have a synthetic estrogen and a synthetic progestogen, known as synthetic progestins. And we'll put a chart up here too, and someone can. This is just the most common synthetic progestins. There's only 2 synthetic estrogens that I know of, ethinyl estradiol, and then there's a brand new one that is potentially useful as well. But the synthetic estrogen and progestin itself, they have a common theme. Both of them tend to increase SHBG pretty high. And the stronger the estrogen, the more of an increase in both SHBG and platelets you get. That's also going to affect blood clot risk. This podcast is not about oral contraceptives, but just looking at its effect on the SHBG, that is going to decrease your free androgens circulating, and SHBG also binds to the androgen receptor in the scalp. Our friend Ben Barros likes to talk about this as well. So it has a lot of a regulatory mechanism, whether it is bound or not bound to an estrogen. So you think, well, higher SHBG is always better, but that is not necessarily the case. It usually is for hair, but you have to take into account all the other systems of the body. If we didn't have to do that, then hair loss prevention would be much more simple.
Yeah, just give everyone ethinyl estradiol and we've solved hair loss.
Yeah.
But no, I think oral contraceptives are really interesting, and there's a number of different things that have been looked at here. And I don't have the studies pulled up because this isn't necessarily an oral contraceptive podcast, but some of the things you can see, actually, compared to certain times of the menstrual cycle, you may have better object recognition if you're on an oral contraceptive.
Yep. And
in terms of 3D image rotation, which is stereotypically thought of as a more male dominant skill, more engineers that are male in that field. When you see women who are taking contraceptives, you'll see an improvement in that sort of ability to manipulate a 3D object in space. And I think that's really interesting. It probably has to do with the androgenicity of the progestin that they're using.
Yep.
So probably, I would suspect, just speculating, we're not going to see that with drospiridone, but we might see that with levonorgestrel because drospiridone is anti-androgenic.
Both bind the androgen receptor, and just because it binds the androgen receptor does not mean it activates it. So there's a competitive inhibitor, and then there's also allosteric inhibitors, which bind the receptor, but at a different spot that it's its normal binding spot. And synthetic progestins often do both in multiple systems. So again, we'll try to find that chart that shows its interaction with cortisol's binding globulin, kind of like SHBG, but for cortisol, and only bioidentical progesterone binds it, of course. And then also its interaction with the glucocorticoid receptor. And at some point, we'll just do another full podcast on oral contraceptives, or perhaps it will just be on synthetic hormones in general. That would be fun.
Yeah, I was going to suggest the same thing. I mean, how to design your best oral contraceptive. But maybe for a wrap-up point here, we could talk about, the ultimate no maintenance hair loss stack would be, somebody at the very outset we talked about 0.5 milligrams of Dutasteride, 5 milligrams of oral Minoxidil if somebody is aggressively receding, and is a good candidate and tolerates the medications well. What about a non-hormonal stack? So something that's not going to be systemic. What would you do, or what would you put someone who is, like, let's just say aggressively thinning, but they absolutely do not want to affect their serum DHT? They've read too many horror stories or talked to people that had bad experiences. They're not willing to risk the small chance. They said, no way, but I'll do anything else.
Yeah, very low dose of daily topical dutasteride, or even 3 times a week topical dutasteride, like 0.1% or less, if possible. If they're not open to that, then that's fair. You add in your ketoconazole, and then you might as well add in your topical caffeine as well. And then microneedling for sure, along with a neuromodulator, like incabotulinum toxin or daxibotulinum toxin, ideally injected, and might as well inject it with some PRP, maybe even reconstitute it with some GHK, copper, or other things that we have ideas that we will discuss down the road.
Yeah. I think we could even do a whole podcast on just designing a hair loss prevention protocol. Like, when should you start thinking about it? I mean, if you're 20 years old and you have no thinning, do you even need to do anything? Should you wait till you're 25? These are questions that I'm sure we'll dive into in an AMA hair loss episode, which I'm sure we'll get a ton of comments and questions after this comes out.
Yep. Please leave all your comments in the section below. We'd love to answer them and do a follow-up Q&A on this. This is one of our favorite topics. I suppose 1,000-foot view on hair loss prevention. It's kind of similar to HRT management or natural hormone optimization. Because a lot of these things do go systemic, your healthcare provider should be adept at all the organ systems in the body and know the effects, both positive and negative, on all of them.
Yeah, I think that's a really good take-home point for people, and just finding someone who's willing to collaborate with you for your unique healthcare goals. Some people have zero hair loss prevention goals. And some people, it's very important to them. It may be tied to, like, let's say somebody's an actor or an actress, that could be very important for them relative to someone who is a just shave it bro. And they really could care less if they have hair or don't have hair. So let us know how many hairs you have per square centimeter in the comments. And thank you for listening.
Thank you, guys.